So, do we agree on this first statement that surgery should be the treatment of choice for T1 and T2 oral cavity cancer?
Yes. As we talked yesterday in more general terms in the first session, early cancers and certainly the T1, T2 that you reviewed, there would be certainly no role for multimodality approach there. And surgery would be the primary treatment.
It's absolute that for early cancers, if we do the radiation, the radiation has a morbidity to the oral cavity is very serious, and if we can choose the one treatment modality for this early cancer, I definitely choose the surgery.
Okay, so there's no point of discussion. What do we do with T3 and T4? So we have now different modalities to choose from, and we have induction or neoadjuvant chemotherapy, and sometimes this is also added by radiotherapy. Then we do surgery perhaps, then afterwards another adjuvant treatment, or we start with surgery and have postoperative radio or radiochemotherapy. What is the general approach which you favor in your institution?
Yeah, this oral cavity cancer is biologically more aggressive tumor than larynx or oropharyngeal cancers. So we need a little bit more aggressive treatment also. And in that point of view, the surgery must be better for the primary treatment. But after the surgery of the very extensive tumors, T3, T4s, the patients will be suffer from very severe functional problems afterwards. And also, the patients also need a postoperative radiation. So in that case, it will be better to try the organ preservation trial. Maybe we can use the concurrent chemoradiation, but the concurrent chemoradiation also induces a very more severe xerostomia and complication and lower survival rate. So in my institute, we prefer induction chemotherapy first. And one or two courses of induction chemotherapy, we evaluate the radial tumors, and if there is a good response, then we can continue to concurrent chemoradiation, only using one chemotherapeutic agent. And if the tumor is not so responsive, the responsive is not so good, then we go to surgery, then followed by radiation. That's my principle.
Dr. Forestier?
Well, I think it depends on there are different T4s. You can have a small T4 a small tumor involving the mandible, and so we certainly would not want to use rely on chemotherapy and radiation in that setting to be the curative treatment modality, and that type of patient could be approached with surgery and reconstruction probably very nicely. So I think when we're talking about a combined modality with chemotherapy and radiation, first of all, we're talking about sometimes these massive tumors. You showed one in your presentation where the whole oral tongue is involved in extension to the floor of the mouth, and the whole area is fixed. Those we've treated with concurrent chemoradiation and had some very nice results. There are some studies in the literature where people have used induction chemotherapy and then followed that with radiation. As sort of a general caveat, the oral cavity cancers have tended to be not as sensitive to our cisplatin-based therapies as other sites. But we have had some excellent results with that approach. Certainly any cancer in the oral cavity that would be technically unresectable with best reconstruction would be approached in a combined modality fashion with chemotherapy and radiation.
Right.
Yes, well, I explained it into my talk. I think that, like Dr. Forestier says, for those big tumors with invasion into the canal going up, you know, sometimes you have skip metastases along the nerve up to the ganglia in the base of the skull. Surgery is not going to clear the patient from his tumor, so it's a big surgery. We obtain good results with the means of free flaps and peroneal flaps or scapular flap reconstruction, but the problem is that if you are leaving tumor behind, it's not a good solution, whatever this is.
Right. So you already stressed the point that T4 is not T4. So are you lucky with the staging system, which is not so helpful to really distinguish those prognostic groups we encounter in T3 and in particular in T4?
Well, I agree with where you're going, that our staging system is not optimal in terms of prognosis, and that's why I mentioned a smaller lesion that's invading the mandible, and because of that is classified as a T4, but really with surgery and then appropriate neck management, those patients can do fairly well. I think one area that I didn't mention, and maybe you're going to get to, is postoperative management and the findings in the neck that would lead to giving concurrent chemotherapy and radiation, or adjuvant radiation with chemotherapy as opposed to radiation therapy alone. And certainly there's data about level 4 nodes for oral cavity lesions that would suggest a worse prognosis, and that's a group that by and large we've treated with additional chemotherapy added to radiation,
right,
along with the extracapsular extension group.
Right. So you already brought us to the issue neck dissection in oral cavity cancer. You had several parameters. What do you do when you have ipsilateral disease and ipsilateral neck disease? Do you then do contralateral neck dissection?
Well, I think that with good imaging techniques now, we can disclose if there are, you know, minor lymph node involvement on the other side. Of course, you have to treat the ipsilateral neck first, but you can go and do a selective neck dissection on the other side, and it would be very useful for disclosing what is to be done next, if you have to irradiate both neck, and what kind of irradiation you should do, because in our modern technique you want to spare the parotid glands on the other side if it's possible, for the sake of the patient and for the quality of life of the patient. So it may be useful, yes, to have very good multidisciplinary review of the MRI. Like it was alluded to yesterday, you may have a PET scan to disclose also second primaries or retropharyngeal nodes, which can happen. So that may be more useful than to see one or two nodes at level 1 or 2. You remove it, but if you left behind nodes in the retropharyngeal space, you don't do any good to the patient.
Don't you have the impression that, in particular, tongue cancer pretty often shows even contralateral metastasis, and that this wait-and-see policy is probably not the best way, in particular when considering the personality of those patients we have to treat?
Yes. Well, we know that the lymphatic channels are crossing the midline, and you can have microscopic lymph nodes even into the intrinsic muscle of the tongue to begin with on the contralateral side. What was very interesting in the study of Fakih was that if you are doing a radical neck on the side of the lesion, you are maybe forcing the lymph node channels to open up on the contralateral side, and you are picking up another kind of dynamic of the disease.
Yeah. Another question to the surgeons. For for a long time, commando operations were standard procedures. Do you still remove all soft tissue between primary and lymphatic disease when you deal with oral cavity cancer? Do you remove mylohyoid, geniohyoid muscle if you have a lesion in the floor of mouth, for example, and you have positive lymph nodes?
No, usually not. Usually not remove this kind of muscles. I remove the submandibular gland and all the soft tissue, fat tissues surrounding the submandibular gland, and I preserve the accessory nerve always if there is no direct invasion. So I can say that's a radical neck dissection.
What is your opinion? Do you remove all soft tissue in between?
Well,
that you really have a through-going hole in your...
I am not sure that you have to do that for a lesion which are not invading grossly the intrinsic muscles. If you have a superficial lesion, or even those exophytic cancer that are growing out of the tongue, but they are not deep inside, you may do a partial glossectomy, do a separate neck dissection. I am not sure that the en bloc dissection will make any difference for this type of tumor.
Okay. So, yes?
It depends on the infiltration of the surrounding tissues. Yeah,
definitely, yeah. So, we have been talking on organ preservation. When you talk with your patients and consider this type of approach, for example, neoadjuvant chemotherapy and then definitive radiochemotherapy, or you start with definite radiochemotherapy, and the patient asks you, well, doctor, what do we do if we do not succeed? What's your answer?
Well, I think when we're talking about organ preservation, we're first of all, we're talking about a patient that's technically resectable. Mm-hmm. So, and in that population, we have to tell them that if that's the choice to go with a non-surgical approach initially, that certainly, if we're not successful, then the alternative recommendation will be to have the en bloc resection with the best reconstruction possible. At our own institution, at my institution, we do favor a primary surgical approach unless the patient is unresectable, and with modern reconstructive techniques, really most patients do well in terms of function.
Yeah. Dr. Andri?
Yes, I think that we can have this kind of discussion with the patient ahead of the treatment. Mm-hmm. And they have to understand very well what's going on and what will be decided if in case they are not responding the way we wish. But as you said, with the new techniques of reconstruction, we can achieve very good results, even if you take more than half of the tongue and the entire floor of the mouth.
In the primary setting. And yeah. Salvage? Do we really have salvage surgery, or is it perhaps a little bit desperate surgery? What is your impression?
I don't think so. I don't think that it should be desperate surgery. I think that those patients are of high risk of recurrence or necrosis, and they should be followed carefully. And unfortunately, if you do biopsies like in the gentleman I presented, you may do as many biopsies you wish. You will not have a good specimen demonstrating that there is a recurrence, but still the patient is there. He is unable to chew and swallow. He is with a lot of pain, and you are suspecting there is some viable cancer underlying this. So you have to go ahead and treat the patient to give him a better quality of life. That's my opinion. But those patients, of course, have to be followed very carefully. Very frequent observation and repeated MRI, whatever. That's the rule.
I think command of operation is still absolutely indicated when the mandible is involved, and mandible